Hello, my name is Inos and welcome back to my channel. This is Work and Wonder. If this is your first time of seeing my video, please make sure you subscribe and turn on the notification bell. Anytime I post a video, you'll be notified and you come straight here and take a look at whatever video that I have posted. So today we are going to continue with our mental health Osce series, and today is going to be a very short video. I posted a video on the planning station and most people are saying that the problems that I was able to identify per the assessment we did, I only did one, or I gave a care plan on one, and then the others I left it so that whoever is watching the video will continue. But people have been asking for problems for mania and then problems for the depression as well. So what I've done is that I have come up with some problems that you are likely to meet in the manic phase or in the depression phase as well. So I have problems for depression with suicidal ideation. I've come up with about 5 problems, and then with mania too, I've come up with about 5 problems. Some of the problems do cut across, and then I've used that to draw my care plan. So I'll go onto my screen and then I'll show you the care plan that I've been able to come up with. So let's go to my screen and I'll show you what I mean. Yes, so if you remember from the other video that I uploaded, this is the same scenario. So as I said, in the planning 14 minutes, and then it's either it's going to be a community based or it's going to be an admission based, and per this one it was a community based. So we came up with a problem of low mood, which I went over in the last video, so I'm not going to go over this one again, but I'm going to go straight to the other problem that we identified, which was the self-harm. So the nursing problem was that Terry is at risk of self-harm related to severe depression, evidenced by a PHQ score of 20 out of 27, and then by verbalization. And then here our aim of care, I left it blank in the other video, and here the aim is just going to be Terry will be safe and will not self-harm, evidenced by verbalizing that he does not have any thoughts of self-harming. So you can just add that to this one, and then that will do it for the aim of care. And then the re-evaluation to be re-evaluated today, which is the 19th/08/23, and then on every shift, and if clinical condition changes on admission. So if it's an admission based, this is what you're going to go with, and if it's in the community, you're just going to remove on admission and then you just put in the community. As simple as that. So what I'm basically trying to do is that there is a 2-in-1 care plan. It can be a care plan for community based and at the same time be a care plan for admission based as well. And then when we come to our nursing interventions, as you can see, the first one, we are still using the MATARID. So explain and discuss all aspects of care on admission to Terry and gain consent. Terry has consented to this admission and has the capacity to do so and is therefore admitted as an informal patient. So basically we have formal patient and then an informal patient. The formal ones are those that you will need to section them under a mental health act. Basically, the assessment has been done and then admission is needed, but the patient says no. In that case, you have to call in a crisis team. They come and do the assessment, and if they need be, the patient or that person is going to be detained under a mental health act for either assessment or for treatment, section 2, section 3, depending on what the crisis team deems fit for that particular patient. Now, monitor and record vital signs as usual is going to be the same thing. What I'm much interested in is the ones that tackle the problem. So as you can see here, we have to monitor Terry on eyesightness and observation, and then we'll review at the end of every shift, which is targeting the self-harm. And if patient is at risk of self-harming, the patient needs to be monitored at all times. Then we'll also have to remove hazardous equipment and then sharps from the reach of Terry, which is very necessary in the case of self-harming. And then we also have to assess his mental status, his mood, his thought, to see whether he's still having the thought of self-harming at any point in time. And then of course we also have to offer diversional therapy on the ward. And then the rest, I'm not going to read them because they still remain the same, which is we are administering medication, we are referring, we are instructing, and then we are documenting. So now let's go down and then I'll show you. Here you have to input your name, your signature, and then the date, as I said in the other video. So we'll move straight to another problem. So we have a problem of sleep. So if be it the mania phase or in depression, if there is a problem of sleep, how do you um, draw a care plan for it? In the nursing problem, you can simply say that Terry is experiencing a difficulty in sleeping related to depressed mood, evident by PHQ-9 score of 17 out of 27. That, depending on your PHQ-9 score that you get, you can relate it to that. And then that same too is going to be an evidence. The relation is going to be the provisional diagnosis that it gave you, and then the evidence is going to be the number. So here our aim is there should be an improvement in sleep. So Terry would have to verbalize improvement in his sleep. Then when we go to reevaluation, to be reevaluated tomorrow, you cannot really assess a sleep today unless the person is sleeping right now, which is not going to be possible. So we'll reevaluate tomorrow, which means that the patient is going to, whatever nursing intervention you're going to teach the patient, you will enforce it and see whether the next day the patient actually had a good sleep or not. So would have to reevaluate it tomorrow. And then on every shift, if clinical condition changes on admission, if it was on community basis, we would have to reevaluate it on our next visit or on every 2 weeks, because mostly patients in the community are visited every 2 weeks. So here we would have to also explain the same EMATA rate, but let's go straight to the ones that target the sleep. So we'll have to assess sleeping pattern and habit of Terry by encouraging him to keep a sleep diary. We also have to provide information that will improve his sleep, like sleeping in loose clothes, warm shower before sleep, comfortable mattress, warm drink, appropriate lighting in the room. So these are nursing interventions that are targeting the sleep. It's actually helping to address that particular sleep problem. And then the rest remain the same: administration of psychotropic medication if it's in the ward, and then you encourage Terry to adhere to treatment regimen if it's in the community. And then you refer to community psychologists and psychiatrists if it's in the community, and then ward psychologists and psychiatrists. And then the instruct and documentation is the same. So let's quickly move to the next problem, which is nutrition. Nutrition can be a problem in mania, and it can also be a problem in depression. If a person is depressed, it can affect his nutritional status. If they are also in the manic phases, it can also affect their nutrition because they might not even have time to eat because all the time they are hyperactive. So what is the problem? Here you can say that nursing Terry, there is a nursing problem, and then the need. Terry is at risk of malnutrition related to depressed mood, evidenced by history of loss of appetite and not eating for 5 days. So mostly when you are doing assessment and the patient says that I've not been able to eat, you would have to ask the patient how many days, how many weeks hasn't he or she been able to have a good food or has not eaten, and then you can use that as a form of evidence when it comes to your nursing problem or your nursing need. And then the aim is generally to improve his nutritional intake, and then the patient will not be malnourished because this is a risk. So you are basically targeting it. You are trying to address the problem before it even happens. So like when we go to the nursing intervention, I'm going to go straight to the teach aspect, which directly targets it. So as you can see, we have to monitor and assess nutritional status of Terry using the MAS2 every 2 weekly. So 2 weekly if the patient is on admission, and then it's monthly if the patient is in the community. So depending on what type of care plan that you are drawing, if it's in the community, it's a monthly thing that we will do using the MAS2, and if it's on the ward, we use or we assess 2 weekly, and then we see per the outcome, then we will give recommendations. So we also have to assess Terry's likes, dislikes, and preference for any special meal. This is something we'll have to do. So here I've left it. You can see that it's not really complete. So assess Terry's dislikes, likes, and preference for any special meal in the community if it's a community base, and then on the ward if it's on the ward. Then also have to monitor and record vital signs. This is general. Then we'll provide information about maintaining balanced diet at all times. So this is also targeting the potential problem, which is the risk for malnutrition. And then here we also have to refer to the nutritional team on the ward, or we have to refer to the dietitian on the ward. If it's in the community, we refer to the nutritional team or the nutritional support team on the community. So here you can make a direct referral, and that particular referral should be targeted at people who also help to improve his nutrition or her nutrition, as simple as that. And then the instruct and document still remains the same. So now let's look at another problem, which is non-compliance to medication. Here it can be in the depressive phase or in the manic phase. All these patients can be in a state of non-compliant. They are not taking their medications, and mostly once they are not taking their medication, especially psychotropic medication, the patient is at risk of relapsing, especially if they have history of depression or mania or bipolar. They can always relapse once they go off their medication. And here the problem is going to be non-compliant to medication. So here Terry is non-compliant to medication related to lack of information as evidenced by verbalization. So most of them, they might not have the problem, or the reason why they might not be adhering to their medication is because they do not have information about it. They don't even know what the medication does. Or it could also be that Terry is not compliant to medication related to side effects as evidenced by verbalization. So either the patient is having side effects that is not allowing him or her to take the medication, or the patient doesn't even know about what the medication does. So you can relate it to any of these two situations. Now let's go to the aim. The aim is basically improve compliance to medication. So Terry will verbalize improve compliance to medication. Now the reevaluation to be reevaluated today on and then on every shift, and if clinical condition changes. So this is if it's an admission based, and basically in the ward non-compliance doesn't really happen because you'll be the one that will be administering unless the patient is on self-administration, and even that on the ward you would have to more or less supervise the patient to take the medications. The patient don't keep the medications. They are kept in a treatment room, and then when it's time, you prompt the patient, you stand by your trolley, and then you watch the patient take the medication himself. So here, non-compliance on the ward is not really popular, but in the community, it is. So in the community, you have to reevaluate 2 weekly in the community, and then as and when clinical condition changes in the community. Here you can be either 2 weekly, fortnight, or on every visit. Any of them that you write is right. So here I'm not going to read the E and then the M. I'm going straight to the teach, which will be assess reasons for non-compliant, and then factors affecting it, provide information on importance of adhering to treatment regimen, and then ensure adequate information on effect, side effect of each medication is provided to Terry. So these are 3 things that are targeting the non-compliance, and once these are ensured, this will help improve the compliance to medication. And here you have to refer to the psychiatrist for medication review in cases where there is a lot of side effect, or the patient doesn't even know anything about the medication. The instruct and then the documentation is the same. So now let's move to another problem which can be prevalent in either the depressive phase or the manic phase we will have, which is self-care. So basically they are not able to take care of their personal hygiene. So here you can say that Terry is experiencing difficulty in self-care, which is ensuring personal hygiene related to depressed mood evidenced by unkept appearance and not bathing for the past 5 days. Especially in depression, they are going to tell you that I'm unable to bath, I'm unable to wash, and then this has been going on for this number of days. They will open up and tell you. For manic phase, they will tell you that they've been so much engaged in something that they don't even remember to even take their bath or ensure their personal hygiene. So this self-care deficits can either be in manic phase or in the depression phase. This is a problem that can cut across, and you can write your problem as I have stated here. And then the aim is going to be thorough verbalize improvement in personal hygiene, as simple as that, and then to be reevaluated today and then every day on admission. So if the patient is on admission and is an admission-based care plan, you would have to ensure that each day you assess to see whether the patient is ensuring his personal hygiene or not. And if it is in the community, on every visit or every 2 weeks, you can, assess to see whether patient is, taking care of his personal hygiene or not. So we will move quickly to the teach aspect, which addresses the problem. So you can see assess self-care habit and explore reasons for not maintaining it. That is one of um, the nursing interventions. And then the second one is provide information on importance of self-care. and then prompt Terry on daily basis to take care of his personal hygiene. So here, if it's on the ward, you can always prompt the patient, and if it's in the community, you would have to involve the carers or the patient's family members to always prompt that particular patient to take his bath at a certain time, so that this will help improve his personal hygiene. And then the administer medication, instruct, and then documentation remains the same. So we'll now go to risks for injury. For risk of injury is only prevalent in the manic phase because they are so much hyperactive that sometimes they do step on sharps, and they do injure themselves. They can have a cut, but they will never be bothered about it because they are so much fixated on doing something that they don't even care about the injuries that they have. So here we can say that the problem can be that Terry is at risk of injury related to hyperactive or restlessness evidenced by history of self-injury. So most of them in the manifest, if they have injuries, you will see that in exam situation they might put plasters and what have you on the patient forehead, on his legs, and then even in the overview of the patient history, you will see that patient stepped on a knife 3 weeks ago or 4 weeks ago and had a cut, and they are going to state something to show you or to tell you that patient has history of self injury. Now the aim is Terry will be safe and have no injuries. That is just the aim, as simple as that. Then the reevaluation is going to be reevaluated today and then on every shift, and if clinical condition changes. So now I'm not going to read the E and the M. I'm just going to go straight to the ones that directly target the self-injury, which will be monitor Terry on eyesight observations if it's on the ward. And then we also have, you have to assess the mental health status, including the mood, affect, thought, and then behavior. And then you have to assess Terry's activity level every shift, because in many phase they are so hyperactive. You would have to assess the activity level, and then you'll be able to plan their day with them. Then you ensure that all sharps and hazardous equipment are removed from Terry's surroundings. These people are prone to injury, so you have to make sure that anything that will injure them, you take it out of their way. Then you have to involve Terry in ward activities. Um, Mostly manic phase, or in the manic phase, they are so much involved in doing something for themselves. So if you don't distract them or involve them in ward activities, they will always be on their own, trying to, trying to do that thing that they are so much fixated on. And then you have to also ensure protected rest period. So you'd have to draw a care plan for this particular patient on resting at in between 2 and 3. These are your rest period, and then you can always prompt the patient anytime on the ward to have a sleep. If it's in the community, you have to involve the family members to ensure that at this time the patient would have enough rest. And then you also have to provide one-on-one support to allow Terry to ventilate his thoughts. Most of the times in many phases, they are so much into doing something, so you have to assess them to see. Sometimes they have some form of grandiose, thoughts. They think they are, with a bit of delusions, they are president, and they are the president of the world, and they have so much to do. So you always see them doing something, jumping up and down. So you have to assess their thoughts and then their feelings. And then of course you administer your prescribed psychotropic medication. In this case, mostly the medications that can relax them, the promethazines, the lorazepams, those ones will relax them, will help to calm them down when they are very much hyperactive. So the administration of these medications is very, very important as far as the nursing intervention is concerned. And then of course the instruct and then the documentation is the same. Yes, so that is all. So as you can see, in this care plan, I have picked all the possible problems that you can see, whether it is depression with suicidal ideation or it is mania. These problems you can find with a patient, or the patient is likely to exhibit these problems, or the patient is likely to tell you these problems, and that is the care plan that I have drawn for each and for each of these problems. Yeah, so basically that is it. What I'm going to do is that I'm going to create a Google Drive, and then I'll leave the link in the description under the video, so that when you click on the link, it will send you to Google Drive where you can download this care plan that I have drawn. But then if you don't watch the video to the end, I am going to put a password on the Google Drive. If you don't watch a video to the end, you will not know exactly where I put the password. The password is somewhere in the video. So please make sure you watch the video and you will see the password. You can log on to Google Drive with the link that I'll provide in the description, and then you'll be able to have access to these care plans that I have personally, designed or drawn. I might remove some things, I might add some things, because I'm trying to create a website where I'll have all these materials uploaded. Yeah, so that has been the video for today. My name is Enos, and this is Work and Wonder. Please make sure you subscribe to the channel and turn on the notification bell. Anytime I post a video, you'll be notified and you'll come straight here and take a look at the video. Until we meet again in my next video, it is a bye for now.